Okay, so we're gonna move on to actually establishing an airway, and let's start with another question. So you have a 2-year-old previously healthy girl who's developed a progressively worsening bark-like cough in the past 3 days. Her parents bring her in because she's now refusing to eat and talking very little. She's leaning forward, drooling, and working hard to breathe with deep retractions. Her SAT's 90% on room air. How do you respond? A, perform a rapid sequence intubation. B, provide racemic epi and dexamethasone. C, place her on non-invasive positive pressure ventilation. D, humidified oxygen while gathering a difficult airway team. And E, call surgery for veno-venous ECMO cannulation. Okay, so the answer here is D, and let's review that. Some of you may have kind of moved towards either the rapid sequence or treating what is probably a bad case of croup with racemic epi and dexamethasone. I think the parts of this question were meant to bring out that you basically have a child that's about to lose their airway or is really struggling, right? The drooling, the leaning forward. But the point is you still have an airway, right? This child is still satting 90% on room air, and so with a little oxygen supplementation, you're easily going to get up to 100% and be able to pre-oxygenate, right? So you don't want to jump to the rapid sequence if you don't have to, right? If you have the ability to pre-oxygenate, give yourself a little bit of time in case this airway is really difficult once you get in, always take that opportunity, right? And I think that's true throughout critical care medicine. So you just want to get the oxygen on board, get the SAT to 100, keep it at 100 for several minutes. That way you have a reserve so that when you do go to sedate and potentially paralyze this child, you have a backup plan. And then in addition to that, you really want to get the best people who are going to be able to intubate present. So that may be you, but in some situations it may be anesthesia. It may be alerting the NT that you have a difficult airway if you think this is going to go to trach. This is obviously a situation that these days is more often bad croup. In the old days, meaning like when I was a resident and we still had some cases of non-immunized Haemophilus influenza, we would see epiglottitis, right? But this is a situation where you're about to lose an airway. Now, the other choices here are not wrong in other situations, but just for this one. So intubating without pre-oxygenating really just increases your risk, as we talked about. In terms of treating the croup, I mean, ultimately you want to do that, but getting the airway is more important since this child is really imminent in terms of losing it. Anything that's going to agitate the kid like NIPPV is not a good idea. So generally speaking, if you have stridor, positive pressure can be helpful, but in a child who's already kind of on their last legs, if you throw on positive pressure and they hate it, you might lose your airway right there when they start fighting. And then finally, VV ECMO as a go-to is really extreme, right? I mean, chances are you're going to be able to get an airway and everything's going to be fine. Okay, so talking about indications for intubation. So obviously respiratory failure or impending respiratory failure, which really means that the child's failing to oxygenate or ventilate. Now, oxygenation is obviously much more critical than ventilation. So if you're about to lose oxygenation, that is, you have minutes and you got to get an airway. If you're just hypoventilating, such as an asthmatic who's very hypercarbic, you do have options like NIPPV you can go to before having to secure the airway, as long as they have the mental status to support that. So that gets us kind of the next point, which is you have to have a patient whose airway reflexes are not compromised. We often talk about GCS less than or equal to 8 as an indication for intubation. Note that that is from the trauma literature, so that's not universal. If you have somebody who has medical illness and they're starting to become more somnolent, you don't have to intubate them at GCS 8, but at some point, if they're no longer achieving a gag and a cough and really clearing their secretions, then they're no longer maintaining their airway. And that's when you really got to get to securing the airway, or else at some point you're going to lose that airway and have a critical situation. And then finally, in situations of neuromuscular weakness, where in addition to maybe not ventilating well because of breathing, they might be not able to expel secretions or clear their own oral secretions, that's a problem. Hemodynamic compromise is kind of a relative, and I think you need to be careful about this, because if you're dealing with somebody with right heart failure, or I shouldn't say right heart failure, with pulmonary hypertension, right, you could make things worse by intubating them. On the other hand, with left heart failure, most of the time you're going to improve things as long as the reduction in afterload offsets the reduction in preload. Intracranial hypertension is a case where we'll often secure the airway at the point where they have become so out of it that they can no longer support their own airway. If a child is ventilating themselves adequately, this is a double-edged sword because, for example, if you have a DKA situation where a child is Kussmaaling and taking huge breaths, there's a very good chance you're not going to match that with invasive positive pressure ventilation. So you have to be cautious about whether you really have to do it or not. And I think the linchpin there is how is their mental status and their ability to support their own airway. If they don't have it, you have to move to intubation. Inadequate respiratory drive is pretty obvious. And then in cardiac arrest, I mean, they're not breathing at all. So at some point you have to secure the airway, although the literature has shown that doesn't need to be your first priority. And, as long as you're able to provide high quality CPR while doing this, then you should move in that direction. But bag mask ventilation is definitely acceptable to get your compressions done first and if need be, defibrillation. Things to prepare for intubation. You want to basically be ready to sedate and do neuromuscular blockade. Some people are a little skittish on neuromuscular blockade. I will tell you that the majority of studies that are out there support the use of neuromuscular blockade to get a better view. So really, if you're not confident that you can paralyze, you should be asking yourself if somebody else should be getting this airway, right? Because using paralytics often leads to a better airway. There are some exceptions. There are situations where you may want to do an awake intubation, but that's a very different technique than your typical rapid sequence. You want to make sure you have your personnel and equipment in place as well as monitoring. So obviously, have a bag mask ready with oxygen flowing. You want to have a suction prepared. You want to have, at the very least, a pulse ox with saturations and ideally an EKG, just to make sure that you're monitoring as you're progressing through this. You want to get your endotracheal tube sized to what you think you're going to place, and then generally speaking, a half size down in case you get into trouble where you just can't pass that tube. And I put on here some of the calculations for how to come up with the right size for different sized children. Finally, it's helpful to have airway adjuncts. Not absolutely mandatory, but nasal and oral airways have definitely gotten me out of a few situations where we had difficult airways, and then having a backup plan. So if you're unable to intubate, what is your backup plan? And I will say that the number one backup plan, I think in almost every situation, is just being able to bag, right? And there's been situations I know where I and many of my colleagues have bagged for 20, 30 minutes until we can secure the airway, whether fiber optically or with the NT. In that situation, the nasal or oral airway becomes really helpful, okay? Because you may not be able to get the airway open otherwise. So with that in mind, here's just some of the various adjuncts. So you can see a picture of a bunch of different oral airways and nasal airways. I think one of the advantages of nasal versus oral is that it's not as kind of gag eliciting, and so you don't have to have someone that's completely out of it, deeply sedated, paralyzed to place a nasal airway. You do need that for an oral airway because they'll try to spit it out otherwise, and it'll actually make your airway worse. You see what the face mask is. I think most of us use the transparent ones, maybe in anesthesia, you're using other things. And then there's a variety of tube options. You can see the armored tubes that are meant to kind of sustain the collapsing of the airway. There's specially shaped nasal airways. And then there's other options for getting airways. So here you're seeing a variety of LMAs. There are combi tubes. There are basically supraglottic airways, right? That are airways that you place and you inflate a couple of balloons, and those balloons then allow you to separate the airway from the esophagus, and in doing so, to be able to just ventilate the airway. I think those are mostly used pre-hospital, but that can be your backup plan if you just can't place an airway, but you can get a view at least down to the esophagus. Okay, pediatric intubation, requires different sizes, and so we talked about the sizing. As I mentioned, cuffed DT tubes really have become the norm in many situations, at least in the ICU. I think anesthesia still in neonates will use uncuffed tubes, but they have a much more controlled situation than what we're often dealing with. And then obviously the depth is an issue, and it's very easy in kids to mainstem an airway, right? And so just be aware of where you want to be, but also be careful to listen. I've listed some of the different intubating medications. I think probably ketamine is a favorite at most institutions that I've seen, but there is not a recommendation that you use one over the other as long as you have the child adequately sedated. For your younger children, using atropine to prevent the vagal response is helpful, because otherwise you may see some significant bradycardia. And then for paralysis, if you're doing a rapid sequence intubation, succinylcholine is definitely faster than rocuronium, but we will sometimes move away from succinylcholine in pediatrics because we don't know if this child has some kind of neuromuscular disease that is going to create problems like long-term paralysis, or potentially give you a hyperkalemic response. So often we'll use rocuronium, but just be aware that rocuronium takes a little bit longer. So whereas Sux is usually about 30 seconds, rocuronium is about 45 to a minute. And then rocuronium lasts longer. So at intubating doses, which is really 1 to 1.2 milligrams per kilo, rocuronium is going to give you a full 30 minutes at least of paralysis, whereas succinylcholine is just a few minutes. So that's one of the advantages. So with your older children, where you're not concerned about neuromuscular disease, Sux is an option, and it's great that it's quick on and quick off. Here I list some of the different laryngoscope blades that people use, and this is not mandatory. You may be comfortable using Max for everybody or Miller's for everybody, and you're welcome to just whatever is good. I think increasingly, I didn't put this into the talk, but the use of video laryngoscopy has become more and more common. And actually, there was a recent RCT done in the New England Journal that in adults, mostly in emergency room and ICU settings, with fellows and residents intubating, where definitely video laryngoscopy had a higher first pass success rate. That doesn't mean that you're not fine to use a standard laryngoscope. I can tell you I do, just because that's what I've done for years, but your video laryngoscope can be a backup option if you're not getting a good view. So proper endotracheal tube means, first of all, having a tube that's inside of the airway, and second of all, having it not too deep or too shallow in the airway. So verifying that it's in the airway, I think most of us use capnography. Be aware that this classic color change, the purple to yellow, does require about 10 millimeters of mercury of CO2 to change. And so first of all, if you do an esophageal intubation, you may initially see this color change, but then it fades with a few more breaths, okay? And so you definitely want to watch for several breaths that you're getting a clear purple, yellow, purple, yellow. And once you have 3 or 4 breaths, you can be pretty confident you're in the right spot. If this is a cardiac arrest situation where there's low cardiac output, you may not see this transition because the amount of end-tidal CO2 may be really so low that it's just not changing, or maybe it's turning a light yellow, so it's barely transitioning. In that situation, waveform capnography may be more helpful, because if you're seeing kind of a persistent, 8 millimeters of CO2 every single time, that's actually someone who is intubated but just has a low output state, and that just speaks to needing to get return of spontaneous circulation. Some adjuncts, if you're about to bronch a patient, that's an acceptable way to make sure the airway's in the right place. Auscultation, we all do it, but particularly in the smaller kids, it's very difficult to be able to hear confidently that you have a main stem intubation. Often the vibrations and just the way sound passes through their lungs, they sound like they're breathing anteriorly well bilaterally. It's a little bit better if you go posterior to the back of the lung. So for that reason, chest x-ray is probably still the main way that we will look at ET2 position. Here I'm showing you an x-ray of somebody who's main stem intubated. You have collapse of the left lung, and so this will very quickly fix up if you just pull the tube back a couple of centimeters. One technique that has been used and validated is to actually, in infants in particular, where you only have a few centimeters to play with, to actually purposely intubate the main stem, listen to the change as you're auscultating in noise, and then back up until you hear clear breath sounds within the left lung, and then from there go back 1 more centimeter, and that usually gets you right in the mid-trachea. So that's just one technique that's possible. Nasotracheal intubation, this is something that is not going to be done in an emergent situation, but may be done in the OR for certain cases to allow the surgeons access to anatomy, but also if you have a somebody who's going to stay intubated for a while, nasotracheal intubation can be a lot more comfortable because our gag reflexes in the posterior pharynx and the back of the mouth are far worse than what it is coming through the nose. And so that's why our patients who are awake can tolerate NG tubes, but they can also tolerate nasotracheal tubes better than orotracheal tubes. So relative contraindications are just if they have maxillofacial injury or basal skull fractures, and you definitely can get issues with bleeding. Generally speaking, you have to use slightly smaller tubes through the nasal route. So rapid sequence intubation, we've talked about this a few times. There's a variety of reasons why you might do a rapid sequence intubation. I think anytime you have an emergency and you just have to get an airway quickly, you have to go with the rapid sequence route. And the idea of rapid sequence is that you're going to simultaneously give a sedative that's going to completely take out the patient and at the same time a paralytic. And so there's no time between the sedation and the paralysis to really confirm that you can bag or that you have the ability to pre-oxygenate, right? So you're essentially going to do this rapidly and then just get an airway. And during that interim from when you sedate, paralyze to when you place your tube, the patient may desaturate because you may not be able to bag. You may have an airway that's full of blood, vomit, variety of things. And you just have to kind of live with that and get the airway as quickly as possible. So really in doing a rapid sequence, you first want to make sure that's the best way. So you want to plan, you want to position your patient as optimally as possible because you really do want to get that airway on the first pass. And so that just speaks to the height of the bed, where the head of bed is, relatively where their head and their shoulders are positioned. If this is a patient that is still breathing spontaneously well, you have the option if they're on, for example, a nasal cannula to turn up the flow, or if they're on BiPAP to turn it up to 100%. So try to pre-oxygenate. I'm not saying don't do that. It just may not be a great option for you. And then make sure you have gathered together everything you need, including things for a backup plan in case you can't get your airway, and then move to sedating, paralyzing, and then securing the airway. This is a rapid sequence intubation is something that is recommended if you're dealing with a full stomach, which a lot of times with pediatric critical care cases, we either don't know if they have a full stomach or they may have one and we're aware of it and we just have to intubate anyway. And so there, as opposed to the OR, you need to make sure they can't vomit at you, which is why we're doing rapid sequence. Okay, so that kind of gets you through the rapid sequence strategy. And so what are some of the complications of intubation? Obviously, not getting an airway, right? Losing an airway. And so that's why there's an important emphasis on having a backup plan and knowing who you can call, but also what you can do right there at the bedside. If you are pushing too hard, you can definitely traumatize the airway. You can tear the trachea, which causes pneumomediastinum. Depending on what you do with the neck, you can injure the C-spine in some cases. You can cause a lot of bleeding with your laryngoscope. You can knock teeth out. So there's a lot of bad things that can happen with intubations, and a lot of them go away as long as you're progressing kind of with experience and in a stepwise manner. I think leaving an ET tube in for a long time is going to get you into problems with things like subglottic stenosis and granulation. And as opposed to like adult critical care, I think this is one where I see us struggling in pediatrics. A lot of times we will delay tracheostomy probably longer than it needs to be. And I see more cases of subglottic stenosis than we probably should. And so, if you're going on a few weeks of intubation and it doesn't look like there's any end in sight, you should really be moving towards trach if you're not already there. Cases of vocal cord paralysis can happen by injuring the arytenoids themselves or the muscles that are controlling them. And then finally, if you extubate somebody, or if you try to intubate and you're unable to, but you do the laryngoscopy, you can precipitate laryngospasm and bronchospasm. And so if they shut off their airway, that'll give you a really bad post-obstructive pulmonary edema. I didn't put bronchospasm on there, but that's another cause for desaturations when you intubate, is if they're not adequately sedated, they can bronchospasm. And so just giving albuterol down the tube is often helpful. Okay, so that's kind of everything in a nutshell about intubation. Is an important topic, obviously, because the airway is one of the quickest ways to kill a patient.